This presentation will provide a brief overview of a study looking at whether multimorbidity affects the association between regularity of general practitioner contact and potentially avoidable hospitalisations. Before I begin, I would like to acknowledge the gold, silver and bronze sponsors of the conference for their support. For those interested in this study, it's now published in the Journal of General Internal Medicine, and I would like to acknowledge my co-authors of this work. As we are all well aware, an ageing population brings with it a high prevalence of chronic illness and ever-increasing expectations in service delivery. Policies have been implemented to reduce demand on health services, focusing on shifting service delivery from the acute to the primary care sector, with the aim to reduce costs and demand on hospitals. The mechanism for this shift is the idea of chronic disease management, i.e. to prevent chronic conditions from reaching a level requiring acute care. This is all premised on the theory of ambulatory care sensitive conditions, that admission to hospital can be avoided through early diagnosis and monitoring in primary care. In our study, the phenomenon we aim to capture using individual level data is longitudinal continuity via a metric called regularity. The aim is to differentiate between reactionary or ad hoc and proactive or ongoing contact as a marker of chronic disease management. This diagram shows how regularity is constructed from individual level data. Briefly, over a predefined period of time, the number of days between GP visits are captured for each individual. The equation shown produces a value between 0 and 1. 1 represents perfect regularity. Importantly, this metric measures how well distributed GP visits are over the time period, not how frequently, and therefore captures longitudinal continuity. In this particular study, we are focusing on multimorbidity, which is defined as 2+ conditions. Multimorbidity is increasingly common and increases with age. It infers a higher risk of iatrogenic harm, largely through issues with polypharmacy. Suboptimal communication between healthcare providers in patients with multimorbidity increases the risk of inappropriate and inadequate care. We have previously observed decreased rates and costs of potentially preventable hospitalisations with increasing regularity of GP contact, and these associations have been independent of both continuity of provider and frequency of contact. This relationship has made regularity a suitable target for policy. However, the impact of multimorbidity on this association is unknown. Given the increasing prevalence of multimorbidity, understanding how it modifies the association of regularity and potentially preventable hospitalisations is important, since this may provide additional information for policy development. The aim of this study was therefore to identify the role of multimorbidity in modifying the relationship between regularity of GP contacts and the risk of potentially preventable hospitalisation. We used data from the 45 and up study, which is the largest ongoing study of healthy ageing in the Southern Hemisphere, containing data on more than 250,000 men and women aged 45 and over in New South Wales. The data includes self-reported, socio-demographic, psychosocial, self-related health and health behaviours linked to administrative data. The design of the study was cross-sectional, with extensive look-back to include both self-reported data and prior health service use, including prior hospitalisation. The exposure was regularity captured between the 1st of July 2012 and the 30th of June 2015. With the outcome potentially preventable hospitalisations captured over the same period. Since the definition of a potentially preventable hospitalisation is not standardised, we captured it in 3 different ways. The broadest definition was any unplanned hospitalisation. The second definition was more restricted to any hospitalisations for a chronic ambulatory care sensitive condition previously identified by the Australian National Health Performance Framework. And the third, which was the most restricted definition, was the unplanned hospitalisations for chronic ambulatory care sensitive conditions. Multimorbidity was captured using the RX Risk Index, which is a count of the number of comorbidities based on prescribing data. We used a look back of 5 years from the 1st of July 2012 to capture multimorbidity. The analysis was undertaken using multivariable logistic regression with an interaction term for multimorbidity and robust standard errors. We also calculated population attributable and population unattributable fractions to estimate the potential change in the impact of regularity in a hypothetical scenario where everyone in our cohort had attained the highest regularity. The results of this analysis are not shown in this presentation in the interest of time, but can be viewed in the paper. The next 3 slides show the results of the multivariable logistic regression across the 3 definitions of PPH in terms of the predicted probability of a potentially preventable hospitalisation. Each slide has 2 graphs. The left-hand graph illustrates the predicted probability on the y-axis of a PPH for an individual in each regularity quintile, lowest to highest, depicted as the coloured lines with 95% confidence intervals across multimorbidity, which is on the x-axis. If there were no effect modification of the association by levels of multimorbidity, the lines would be parallel. In this graph for unplanned hospitalisation, you can clearly see that as multimorbidity increases, the lines get closer together. However, of note, the lines are still arranged in order of increasing regularity, although by the highest multimorbidity, there is no significant difference across any but the highest regularity quintile, which remains associated with a lower probability of potentially preventable hospitalisation. The graph on the right-hand side of the slide presents the same information, only this time comparing each regularity quintile with the lowest, depicted as the red line. The y-axis this time shows the difference in the probability of a potentially preventable hospitalisation according to each comparison. Here, if there were no effect modification, the lines would be parallel with the red line, which they are clearly not. This slide shows the same graphs as previously for the more limited definition of the potentially preventable hospitalisation from a chronic ambulatory care sensitive condition. Here we can see that the effect modification is much larger than observed previously, with crossing over of the lines at about RX score risk 5. While the 95% confidence intervals are large with the higher RX risk scores due to the smaller sample size, there is a clear rearrangement of the relationship with regularity. The right-hand slide plot confirms that those with the highest regularity are no longer predicted to have lower probability of a PPH compared to those with the lowest regularity, as we have observed in the previous analysis. The results for the most restricted version of PPH are similar to the previous analysis. In conclusion, regularity of GP contact is an important consideration when designing intervention approaches to reduce avoidable hospitalisation. However, effect modification by multimorbidity on this association would present additional challenges in providing optimal care for people with multimorbidity. This study shows that the association of regularity and hospitalisation significantly weakens with increasing levels of multimorbidity. Therefore, additional strategies to support primary care as a hospital avoidance strategy are warranted. I would like to acknowledge the participants of the 45 and up study, the data custodians, and the NHMRC who funded this study. Thank you for listening.